Hello, friends. Have you heard of LPA, also known as apolipoprotein A? Perhaps you have gotten this test done from your primary care doctor or your cardiologist, and your numbers are high, or someone you love has a high risk for cardiovascular disease. And you might be wondering, what can you do about this? I'd like to show you some research here on whether aspirin can actually help reduce the risks from LPA, specifically for heart attacks and the risk of dying, as cardiovascular disease remains the #1 killer in our nation. Hang with me, let's get to the bottom of this. And just a reminder that I am a doctor, but I'm not your doctor, so this is not individualized medical advice, just education and entertainment. So, what is LPA? LPA is different than cholesterol or LDL cholesterol. It's actually a molecule in your bloodstream that we think may actually be functional for wound healing and controlling bleeding, but has this negative side effect of causing cardiovascular disease over time. Because remember, the average life expectancy in the Western world around 1900 was around 40 years old, but now the life expectancy is much longer. It's possible that this molecule may have helped people with wound healing in the past, but now, as people live longer, it contributes to heart attacks and strokes. Now, how does it do this? LPA contributes to the formation of artery plaques, also known as atherogenesis, as well as vascular inflammation, because your artery walls get inflamed over time. And LPA also prevents the breakdown of clots when there is a clot. Typically, there are mechanisms in your blood that break down that clot, but LPA may prevent that, which would contribute to clots and blocking blood vessels, which can lead to what we often know of as a heart attack or a stroke. More specifically, high levels of LPA have been shown to increase the risk of cardiovascular disease or CVD. And both for males and females, CVD is actually the most common cause of death, even though many other things get more attention, like types of cancers or infections. And we know that high LPA levels do predict cardiovascular disease. And LPA levels, unfortunately, are largely genetic and are quite resistant to lifestyle changes or changes in diet, exercise, sleep, and other interventions. And at this time, there's no really effective medications for high LPA. So that's the bad news. But what is the good news? We have identified some mechanisms underlying high LPA, and one of them is genetic factors, as I mentioned. So this is a study where they took people's genotypes. Specifically, if you look at the bottom of the graph here, you'll see TT, TC, and CC. Those are different genotypes. And then they looked at their LPA level on the left, anywhere from 0 to 300. And remember, normal is under 30. If you had this TT homozygous variant, you had a very low LPA level of 10 on average. And if you had the CC variant, the LPA level was really high, 153 on average, and something intermediate for an intermediate genotype. What this tells us is that you can predict somebody's LPA level by their genotype, which is good to know because at least we have some kind of mechanism at play. Now, what about looking at actual risks of cardiovascular disease? So here we have another study which actually looked at people's levels of LPA and then how much actual heart disease they had. So over here on the bottom from 0 to 125, the LPA level, and remember under 30 is considered normal, and then the odds ratio for coronary disease. Coronary disease is just another word for heart disease or heart attacks. So if you have an average of, say, 25, your odds ratio is basically baseline 1.0. But as you go up to 125 or even higher, you can see that your risk for coronary disease is something like 500% higher, approximately. And this is quite easily predicted by one's genotype. And here that's being described by the number of variant alleles, which is another term for genetic copies. So there's a strong connection between the LPA level and somebody's risk of heart disease. However, aspirin has been used for decades, maybe even centuries, for various purposes, but we know that it has a specific effect on what's called the platelets in the blood. Platelets are responsible for clot formation during bleeding and also for clot formation in dysfunctional settings, such as in heart attacks. With people who have cardiovascular disease, if they take aspirin, they're going to have a lower risk of clot or thrombus formation. And when they already have some kind of clot stuck in their vessel walls, we know that being on aspirin reduces the risk that plaque rupturing and causing a full-blown heart attack or stroke. And if you just look at people on aspirin versus not on aspirin, overall, for people who have cardiovascular disease, it does impact the risk of actually dying. So that is really cool, and that's why so many people are on aspirin when they're older. But there's also this negative side effect of aspirin, which is that it increases your risk of bleeding, and that can also be sometimes quite serious bleeding, such as having a hemorrhage into your brain or having some large bleeding into your bowels. So it is a slight increase in risk, but it is not a trivial increase in risk. But what about in healthy people? If you're just a healthy person who doesn't yet have heart disease, which I hope is most of the people who are listening to this, should you be on aspirin? Now, that's an individual decision you want to make with your clinician, but we can also look at some research. And if you're a healthy person, generally aspirin is not going to decrease your risk of dying from heart disease. So here are two studies that have been really well done, and I'll show you some of their results. But one thing to note here is that these are studies in healthy elderly people. These are not people who have heart disease already. And what we find is that if you look at these graphs here, these are the number of years since the study started from 0 to 6. And then here you see the cumulative incidence on the left. Incidence just means how likely is something to happen. And when somebody's on aspirin or placebo, if you look at the left graph, we don't see much of a difference in their chance of these cardiovascular events happening. And the same thing is basically observed on the right for other kinds of outcomes, like stroke or dying. So it doesn't look like aspirin's really preventing much if you're healthy. However, we do see one thing that changes, which is the increased risk of bleeding. As you can see here, this is the number of years in the study, and then the left is the percentage chance of the thing happening. And over time, the placebo, which means not being on aspirin, has less of a risk of bleeding. And this is serious bleeding. This isn't just having bleeding gums that go away. This is serious bleeding. That risk also goes over time. And overall, you can see the hazard ratio is 1.38, which means there's a 38% higher risk of bleeding over time. Let's look a little more in detail about how much the risk actually is. In this set of studies, we see that the aspirin group had about 8.6 events per 1,000 person years, which means that if a person lived 1,000 years, how many times would there be a problem with major bleeding when they're on aspirin? It would be 8.6 events, and then on placebo, it's 6.2. So the relative risk increases 38%. However, remember, that's a relative risk increase, which means that how much more risky is aspirin than being on a placebo. And we also have to consider the absolute risk, which means just what's the baseline chance of something negative happening in general. And when we do that, what we see is that the placebo group has about a 31% absolute chance of an event happening. So just by living into your old age, you have about a 30% chance of some kind of major bleeding happening. And when you're on aspirin, that goes up to 44%, assuming somebody lives about 50 years and they're on aspirin, say, for example, from age 40 to 90. So it is an increased risk. However, it's a relatively increased risk. So keep that in mind. And now let's look at a couple of studies on whether taking aspirin actually will help people who have high LPA numbers, which is probably why you're interested in this video. First of all, one study that was done is in this journal, and it's called Polymorphism in the ApoLipoprotein A gene, which means that changes in the gene. And then they're looking at the connection between that and the levels of LPA in the blood and actual levels of cardiovascular disease, and then what happens when you take low-dose aspirin. So overall, the punchline of the study is that you have a 50% reduction in risk, which is pretty cool. So that's a pretty large reduction. And as a reminder, probably this is happening because of the way aspirin just normally works. It reduces the risk of having a thrombus form, a clot. It reduces the risk of that plaque rupturing, and it reduces the risk of death, but it also may increase the risk of bleeding. But 56% is non-trivial. And here's a graph from the study where you can see this is the number of years after enrollment on the bottom, and on the left is the cumulative fraction of the population that had some kind of an event. And the dark line here is people who don't have any genetic risk and who are not taking aspirin. And the only line that's different, the line here that says carrier and placebo. So if somebody has the genes, meaning they are a carrier, and they're on the placebo, they have a much higher risk of having an event, meaning if you have the genetic risk, but then you take the aspirin, you're a carrier and you take aspirin, that's this dotted line here, it looks exactly like somebody who's not a carrier. So just by taking aspirin, your risk will go back to being like somebody who doesn't have the genetic risk. That's what this study seems to suggest. And that is pretty cool to know. I think this was the first time this was demonstrated as far as I know. But there are some limitations here because it didn't actually measure the levels of LPA in this study. They measured the genotype. And also, we don't really have as much of an understanding about the bleeding risk and whether it's actually worse or better than the benefit in reducing mortality from the risk of cardiovascular disease prevention from taking aspirin. So next, I want to show you another study that came later, which is called Aspirin for Primary Prevention of Cardiovascular Events in relation to LPA genotypes. And what they did here in this study is they took about 19,000 healthy older individuals who never had any cardiovascular events, never had a heart attack or a stroke, and then they randomized to take 100 milligrams of aspirin or placebo, followed them for about 5 years, and they measured how many of them had a cardiovascular event, that's called a MACE, and how many of them had some clinically significant bleeding. Those are the two endpoints. And let's see what they found. So this is the placebo arm. So these are people who are not on any aspirin. And over these 7 years is that people who have this higher risk genotype, the one that is TC or CC, that's represented by the orange, as time goes on, they have a much higher risk of having some kind of cardiovascular event, which makes sense. They have a higher genotype risk of getting LPA that's high in their bloodstream, and therefore they have a higher chance of having a heart attack. And you can see by 7 years out, the difference between these two curves is substantial, maybe something like 250% higher risk. Now, what if these people took aspirin? What would it look like? Let's take a look at that. So in the aspirin arm, what is that the people with the high risk genotype, TC and CC, the orange group, over time, as they take aspirin for more and more years, their risk actually winds up being less than those people who don't have that high risk genotype, which suggests that the aspirin is actually inhibiting some of the risk from the higher LPA levels. So it looks like the effect is somewhat protective, specifically for people who are at higher risk. Now let's compare the risk of bleeding with the benefit here. This is a quite involved graph, so let's talk through it somewhat slowly. So first, just take a look at this top set of numbers for major adverse cardiovascular events, or think of that as just heart attacks. And just to keep things simple, try to look where this red arrow is. This just shows you that if there was no difference in the study, everything would be on this dotted line in the middle. But we see that overall you have a general tendency for fewer heart attacks when they're on aspirin, if you average out where these data points go. And then in terms of the bottom set of numbers, clinically significant bleeding, you have a general tendency for more clinically significant bleeding events when people are on aspirin. And like I mentioned, the bleeding includes things like major hemorrhage and intracranial bleeding. So it's not trivial types of bleeding, like a paper cut that won't stop. All right, so this is basically what we would expect here. Let's look at the bleeding risk in another way. What they also did in the study was showed how the bleeding risk can be quantified by comparing people who took aspirin with people who had these genetic variants but didn't take aspirin. And what you can see here in the placebo group, the high-risk group in orange has a slightly lower risk of bleeding over time, and it catches up to the higher risk groups by the end, by year 6. But it is interesting to see that the higher LPA levels actually seem to be protective against bleeding risk, even in the placebo arm. So when people are not even taking aspirin, we see fewer bleeding events with people with high LPA. And remember, that makes a little bit of sense because the theory is that LPA actually prevents people from hemorrhaging and bleeding too much. It contributes to clotting when the body needs to clot. And now let's look at the people who actually took aspirin. What is the risk of bleeding when people are taking aspirin? So if you look at the high risk LPA group, meaning that they have a high genetic risk for high LPA, their risk of bleeding is actually lower than the people who have a low risk of LPA being high. And that is similar to what we see in the placebo arm in terms of the trend. But overall, if you compare these two graphs, you'll notice that being on aspirin does slightly increase the risk of bleeding overall. But again, there's this interesting effect where if you have a high LPA number, you probably have a lower risk of bleeding than if you had a lower LPA number. Let's look at another representation of this. When you look at just everybody and you don't stratify people by genotype, meaning you don't stratify people by their risk of having high or low risk of LPA being high, we don't see much of a difference, meaning we have 1.7 reduced heart attacks, and then you have 1.7 increased bleeding events. So it doesn't seem like there's a net benefit overall. However, if you stratify by genotype, if you actually look at the people who have a genetic risk for having high LPA, and one way of doing that is looking at this one genotype called RS379, etc. here, among this group of people, that you had a benefit of 11.4 events being prevented, but you also had an increase by 3.3 events for bleeding. So you have a net benefit when you're on aspirin if you have this genotype. And then they looked at high risk genotypes another way down here with this thing called high LPA GRS quintile. And similarly, you see a benefit of 3.3 events that are prevented by being on aspirin, and you have an increase of 1.6 events of bleeding. So overall, you have a net benefit for aspirin. So the story we're seeing emerge here is that aspirin is not really helping people who don't have this high-risk gene or higher levels of LPA, but it does seem to help people who do have those higher levels of risk. Now, there's a third study, and I think you'll find this one especially interesting because I think it gets at something a little bit deeper here. In the journal Clinical Chemistry, this is called High LPA and Low Risk of Major Bleeding in Brain and Airways in the General Population Randomization Study. And what this is doing is specifically looking at risk of bleeding. So what they found here is that the higher your LPA genotype, the lower your risk of bleeding in general is. So if you are a non-carrier versus a heterozygote versus a homozygote, homozygous just means you have 2 copies, heterozygous mean you have 1 copy, you have an increasingly lower risk of bleeding. That goes back to the theory that I mentioned that the more LPA you have, it probably protected you from excessive hemorrhaging. But now in our modern context where people are living longer and not getting into axe fights as much, the greater risk is from too much clotting from high LPA and heart attacks and strokes. That's an example of what's called an evolutionary mismatch hypothesis for the origin of disease. And there are many examples like that, including our desire for sweets, which used to protect us from starvation, but now in environments of sugar everywhere, even in impoverished environments, we see the greater risk is things like diabetes. So let's look at this effect in a little bit more detail. And here's another way of representing it. Where the red arrow is, you'll see they're stratifying people by their actual LPA percentile. And you see the people who have the lowest percentile of LPA levels in their blood have the baseline level of bleeding. And then as you get more and more LPA, you have a lower and lower risk of bleeding. And that's essentially what they also see in the other data analysis here. And here at the bottom is a summary representation of the risk. And so overall, that is consistent with the theory that I mentioned. So we're seeing again this connection between higher LPA and lower risk of bleeding. Now, what about if somebody has a high LPA level and we think that they have a lower risk of bleeding generally? Does that also mean that if they take aspirin, they're going to have a lower risk of aspirin causing them to bleed? And that's what we'll turn to next. This is just a little review of what I've just said. You have a lower risk of bleeding when you have a higher LPA. Therefore, it does make sense that if someone takes aspirin and they already have a high LPA level, they should be protected from the excessive risk of bleeding that we normally see from aspirin. And finally, we're going to go to a study that will look at this, but I want to just remind you what we saw in a previous study. Remember this little graph, the higher LPA, you had a lower bleeding risk, even in the placebo arm and even in the aspirin arm. That's really counterintuitive. You might expect these two graphs to basically be the same. Shouldn't aspirin cause a higher risk of bleeding the same amount in people who have a high LPA and a low LPA? Why would aspirin result in a lower chance of bleeding when you have a higher LPA level? So that's really interesting to observe. So let's go to the next study here. This is study number 4. Aspirin and cardiovascular risk in individuals with high LPA. And I think maybe this is one of the more substantial studies on this question, which builds on these prior studies. So overviews here, the overview here is that they took people who had a high LPA and they looked at whether aspirin use mitigated the cardiovascular events that occurred. And these are about 2,000 people who don't have any cardiovascular disease at baseline, and they followed them for 16 and a half years. And the design is what's called a prospective or observational study. And the key thing here is that it's not a randomized controlled trial, so it's not a gold standard study. However, it does give us some useful information. And they wanted to see what would happen to people if they gave them aspirin or they didn't give them aspirin. And they wanted to see how this changed depending on whether people had low LPA or high LPA. And they did a couple things to control for other risk factors and other confounding variables. And the outcome measure that was looked at was the risk of having a heart attack or dying of cardiovascular disease. And what did they find? As expected, the aspirin protected people who had a high LPA. Specifically, for people who had LPA above 50, there was a 46% reduction in risk of a heart attack or death, which is pretty substantial. And using aspirin took these people who had high LPA numbers and basically turned them into people who had low LPA numbers in terms of their risk of cardiovascular disease. So in some ways, the aspirin erased the risk that we have from the high LPA, which is quite astounding. Let's look at some of the quantitative graphs here. Here you can see the number of days in the study going up to 6,000 days, whatever it is, 15 years. And then we have these 4 groups in the study. I'll make this a little bit bigger. So first, on the left, you have the people who have high LPA but don't take aspirin. Those are the people in this purple group, and what is they have the highest risk of having some event, which makes sense. They have the high risk genotype, they don't take aspirin. Next, you have these people with the high risk LPA, but they do take aspirin, and they're in orange. So what you see here is that they're reducing their risk substantially, and they look a little bit more like the other groups down here than they do the high risk group. And then the blue lines are the people who have low LPA, under 50, and then one who takes aspirin and one who doesn't take aspirin. So the first thing to notice there is that the blue lines, whether or not they take aspirin or they don't take aspirin, they don't really look very different. So you're not changing much of your risk if you take aspirin or you don't take aspirin if you have a low LPA under 50. However, for people who have an LPA above 50, we were able to see that this purple-looking graph essentially became the orange-looking graph. And that is really amazing because you're taking all these people who would have had heart attacks and you're putting them into a category of much lower risk. And these are people's lives that were saved. Behind this graph are grandparents and parents who get to be with their children for years and years longer. That is an amazing thing. So let's go now to bleeding risk. The other very interesting thing is that we don't see a significantly increased risk of bleeding when people are taking aspirin in this study. After the experimenters adjusted for all of the confounding variables, other things that increase your risk of bleeding that are not aspirin. So after controlling for all those things, they didn't see that the aspirin actually increased the risk of bleeding in this high LPA group. And just to look at that in a little more detail, here's a more detailed chart. And what we see here is that first, this is a chart that's looking at what is the bleeding risk for the people in this study. And the chart is divided up into 2 pieces. The first is the top, where they're looking at major bleeding events, and then at the bottom, they're looking at specifically gastrointestinal bleeding events. So just looking at the top arrow here on the left, what is that when people are on aspirin, their increased bleeding risk is not statistically significant. It's a p-value of 0.4. And over here, for people who have high LPA, it's a p-value of 0.2. So overall, there's no increased risk that's statistically significant, regardless of your LPA level when you're on aspirin in this study. And specifically looking at gastrointestinal bleeding events, the same thing is seen. The p-value for people who have low LPA is 0.2, and the p-value for people who have high LPA is 0.6. So nothing approaching statistical significance, which would be 0.5. We're far away from statistical significance. And the key thing here you have to remember is that they are adjusting for these other variables that increase your risk of bleeding. What are those variables? Age, sex, race, ethnicity, liver disease, because remember, the liver is involved with clotting factors, hypertension treatment. So if you have untreated hypertension, you're going to have bleeds because even every 10 milligrams of mercury that you have higher blood pressure, you're at a higher risk of stroke, including hemorrhagic stroke. Non-steroidal anti-inflammatory drug use, that's like NSAID use, like Motrin. If you're on that, you're going to be at a higher risk. Anticoagulant use, maybe people who are on blood thinners like Eliquis, systolic blood pressure, as mentioned, GFR, which is kidney function. So if you have kidney dysfunction, that's going to also change your risk of bleeding. And once all those things are controlled for, we don't see a statistically significant increased risk of bleeding from taking aspirin. And I thought this was important because this is one of the better controlled studies for the question of aspirin's bleeding risk for people with high LPA. So overall, just looking at all this complex information, it's really important for people to know their LPA levels, not just their LDL, HDL, triglycerides, total cholesterol. Those are also really important to know, but you have to know your LPA level because it's one of the best predictors of having a heart attack, dying, having a stroke, very serious clinical events. The other really cool thing to know is that aspirin, which is a very affordable, available, and non-prescription intervention, may have a role in the primary prevention of these terrible cardiovascular events in people who have high LPA. Now, you want to always make that decision with your clinician. You don't want to just go out and buy aspirin and start taking it. It is a dangerous drug. You want to carefully be monitored, talk about it with your clinician, and make that decision together in light of all of the information in your medical history. The other thing that's really important is that aspirin use does not have benefits for the general population. It's only going to be people who are in this high LPA level group. Finally, the fascinating thing we see from this data is that having high LPA may actually prevent people from bleeding. And we see that might be the explanation for why people don't have a general increased risk of bleeding when they take aspirin when they have a high LPA level. Because LPA may be an anti-hemorrhagic molecule, and that conserved evolutionary mechanism may be underlying this surprising finding. And of course, we always need more research to replicate this. We need randomized control trials, not just observational studies. But it does provide a lot of hope for people who are getting this result back from their clinician and then wondering, now what am I supposed to do with this number that's really high and that is apparently predicting that I'm going to have a heart attack? I hope this has been helpful for you. And if you found it helpful, please like it so I know that I should make more things like this. And if you find this information useful, please subscribe so you don't miss out on other videos similar to this. Thank you so much. Take care.